So welcome to Our Ladies Room. Today we are going to talk about something very, intriguing and interesting, titled Dataviz, How Public Health Dashboards Can Backfire and What Can We Do Instead. Our speaker is Eli Holder. Welcome one more once again. So this just a bit of like a disclaimer. We like to remind you that this talk is recorded and will be posted on YouTube in our YouTube channel at Our Ladies Room. Please feel free to turn off your cameras if you don't want to be recorded. We do this to ensure a safe, inclusive, and harassment-free space, because this is sort of our priority. We like to provide a respectful environment where everyone feels welcome and is able to learn, connect, and grow. So please remember that all our attendees are expected to adhere to our code of conduct. You can find more about the code of conduct here at ourladies.org/COC. And please use the chat to post your questions, introduce yourself if you haven't done it yet, and so on. Also, I'd like to just say that this talk, what's going to happen today is there will be this talk and then a Q&A session. The Q&A session will not be recorded, so you will be free to ask all your questions aside of a recording environment. So what to expect from this talk? Okay. This talk will provide essential knowledge on equity-driven public health visualization and guide you on avoiding common pitfalls in Dataviz design. So rethinking, we will be talking about rethinking Jon Snow's cholera's map, identifying risk in visualization practices, exploring equity-oriented charts, practical tips for fair and expressive data visualizations. Welcome, everyone. So this is our first event of the year. I have introduced myself. I think I cannot see myself. I don't know why. Okay, so now I can see. So I have introduced myself, and I just take the occasion for say that I am one of the Our Ladies Room organizer. My background is statistics and I specialize in actuarial science, but more within the research of it. So I'm not like commercial actuary. So I haven't experienced that much within insurance businesses. But I spend a lot of time studying. I am now an author, so just waiting for my book to be published. And I enjoy organizing these monthly events because I am a promoter of a safe environment for learning and networking, and that it is identified Our Ladies, and Our Ladies is a global community. So we will be see with how it has expanded within the years, and it's gonna be evolving a bit more. So get ready for another of our interesting talks. Our Ladies is in the market. Let's say we are no-profit registered, no-profit organization that has been funded in 2012 by Gabriela De Quieros in San Francisco, and she's now evolved, let's say. She works now for Microsoft as a artificial intelligence manager, but I spent certain number of years, let's say, organizing and putting people together, providing different, environments for talking and learning and networking, and helped many women that gathered together and helped each other. So it's a friendly community. Arredis Rome is just a couple of years that we had the chance to, set up these talks, and we are still putting like an effort, such an effort in expanding in Rome in itself. So we like to have a bit more Italian join us, even if we speak English, but it's important to learn a second language as well. So we are a local chapter of Our Ladies Global, and we like R as a language for the minutes, but we do not stop that there. Okay, already roaming number. Within these 2 years, okay, our attendees have grown, and we expect to, have even more registrations within the future times. And so we started in officially in 2023. We now have already 1 plus 2K members and 2K plus reservations, and successfully organized 25 plus events. Okay, future speakers, next events. We have Isabella Velasquez. She's Senior Product Marketing Manager at Posit PBC. She's already been one of our speakers, and she will be again because we have something very nice to show you all about Quarto, about some interesting improvements that are coming up soon. And then we have Claudia Vitolo, which is co-founder of Our Ladies Global, and even if Our Ladies Rome, because she's now moved in Rome, and she will talk about the history of Our Ladies Global. So if this is our team, and there is also Raffaella. Hello, Raffaella. And she's our great organizer. She is always doing great canvas, and so the images and the graphics of the events are all by Raffaella. So she's really nice. And even if she's in Brazil. So we hope to invite her soon in Rome, so we can have finally see you in person. If you'd like to be an Our Ladies Rome organizer, please do it. We always welcome people join us, even if it's just for sharing ideas. So I'll put this link in the chat. And this is just a form, a Google form, where you can eventually fill up with your emails and names and everything, and we'll keep in touch. Then we have these 2 QR codes. If you like to suggest a speaker or be one of our speakers, please, again, those are 2 Google forms, just very simple, straightforward, to give us the details for keep in touch with you. Okay, thank you very much. So without further ado, we are thrilled to have with us Eli Holder, data visualization researcher, who will be sharing expertise on how public health dashboards can backfire and practical ways to make them more equitable. Eli brings extensive experience in data visualization, particularly in exploring the social impacts of visualizing inequality and social outcome disparities. Recent work focuses on how design choices in Dataviz can influence perceptions and outcomes in public health. Please join me in welcoming Eli Holder.
Hi, folks. I'm very excited to be here. Thank you so much for having me. Let me get the screen going. Good, good. Can you see me? Yep. All right, cool. Okay. Hi, I'm Eli Holder. This is me. I am a data designer. My firm is 3 is a Pattern. With 3IAP, I work with clients to solve problems in data communication, particularly for data about people. This involves lots of very long reports. Sometimes it's interactive data apps. Other times it's talks and workshops. There's even some creative stuff in here. But what's even more fun about client projects is that it's a way of inspiring research. It's also a way of paying for research. And I'm fascinated by this weird feedback loop between people and data, and particularly the way that data can impact social issues or equity issues or have social impact. For example, we actually just published a new paper a few months ago at last year's Viz conference. It's called Must Be a Tuesday, and we look at the impacts of more equitable ways to visualize population health data. And so I'm going to share some of this today. And to be upfront, this is part of it's a small slice of a much bigger workshop. If folks are interested, the little link at the bottom has all kinds of other information related to this. So for today, this is Deathly Dataviz. And this is kind of a morbid introduction to the equity impacts for visualizing population health. And so since we're talking about Dataviz and public health, of course, we're going to get started here on Broad Street in London. This is John Snow's famous map summarizing his heroic data collection efforts around the 1854 cholera outbreak. You can see each bar here is a case of cholera, and it's all centered around the infamous Broad Street water pump, which apparently contained raw sewage. According to legend, this plot allowed Snow to identify the pump as the source of cholera and convince city officials to shut it down, thus saving all of London with a single chart. And there's maybe more to this story, but in any case, it's an impressive example of kind of the revelatory power of Dataviz. On the other hand, this hot mess of a chart is more unsuspectingly heroic. It's 4 different plots, each of which show that Americans are increasingly interested in exercise. And this chart did something that Jon Snow could never dream of, which is it actually motivated Americans to spend more time working out at the gym. And so in a recent study of 64,000 members of a US fitness chain, people who saw this chart increased their weekly gym attendance by 24%, which is pretty massive for a behavior like going to the gym. And so when we think of good data viz, we often think of things like Jon Snow's maps because good data viz is supposed to be intellectual and enlightening. It works by guiding us towards smarter, more rational decisions. And that's all fine. But there are other ways that data can influence us, and a surprising amount of it has to do with social psychology. For example, this chart on the right is influential not because it supports more rational decision making. It works because it highlights a social norm that people are sensitive to. And so when we see these norms in a chart, we kind of match our behavior to the norms that we're seeing. And so today we're going to talk about some other not quite rational influences for dashboards and charts like these that are published by big institutions like government health agencies, particularly for public-facing visualizations showing outcomes split up by social group. But why do we care about influence? Because public health relies on influence to get things done. This was from a recent conversation I had with a super thoughtful public health leader. He said that the only way that things happen is through collaboration, and he sees his team's work as creating the knowledge that helps other people do their own work better. And this quote was specifically for public health, but you could drop in all kinds of other things: housing policy, program evaluation, data advocacy. As data people, our best shot at changing the world is indirect. We're not making policies, we're not out in the field, but the hope is that our work will have a positive influence on the beliefs, the decisions, and the behaviors of the other people in our communities. Here's where this gets tricky though, is charts like this are influential, but maybe not in the way that you might expect. This shows heart disease mortality split by racial groups for youngish adults in the United States. And this chart is well motivated. It's intended to guide policy decisions, to communicate health risks to specific groups, to motivate protective behavior, and create accountability for government officials and decision makers. And this chart, by conventional design standards, is a pretty good chart. It's clean, it's simple, it disaggregates and highlights contrasts. And these are all good things to aim for if this chart weren't about people, and particularly people from marginalized communities. And the problem with this chart is that it can backfire. This chart is arguably deadly, at least indirectly. Or to be more precise, there are plausible pathways between the misbeliefs encouraged by charts like this and worse health outcomes for the populations being covered. And so we're going to cover some gloomy topics today, but the good news is that we can do better, and not just better, provably better. And to do this, we need to be a little bit more deliberate in designing Dataviz that's not just effective, but that's also equitable. And so my goal for today is to try to paint a path forward towards more effective and equitable public Dataviz. And this means fewer charts that backfire and more charts that have a more positive influence. And to do this, we'll cover two big themes. One, we're going to talk about some of the unintuitive ways that people misjudge data, particularly data about other people. And at the same time, I want to share some more proactive steps we can all take to try to make this happen. And this will be both specific practical tips for better charts, but also a more general strategy for producing more human-friendly data viz in the long run. And so to get us into the right mindset, we're going to start by asking, what's the worst that can happen? Can accurate, well-intended information backfire? And so I'll share some examples of this, but I'd love to hear any data disaster stories that you guys have. So feel free to throw them in the chat. And I'll pause at the end if somebody wants to share. So our first example is a chart that shows lifetime risk of lung cancer for 4 different groups of people based on whether they smoke and based on whether they've been exposed to radon. And the goal for this chart was to help people understand the risk of radon exposure, particularly for non-smokers whose cancer risk jumps from 1% to 5% if they're exposed to radon. But what effect did this chart actually have? It seemed to convince non-smokers that they were immune to radon exposure. It had kind of an invincibility effect. And that's because people understand health risks not in relative terms, but in absolute terms. And so even though 5% is a lot bigger than 1% for non-smokers, 5% is still pretty small compared to the 31% for smokers. And so non-smokers seem to mistake their lower relative risk for no risk at all. And so not only does this chart fail to increase risk perception, it actually backfires and seems to reduce it in some cases, thanks to these contrast effects. And this is another one looking at health disparities. And there's kind of a common belief that raising awareness of health disparities will magically help solve them. And if that were the case, then when people read something like COVID-19 disproportionately impacts racial and ethnic minority populations, then you might expect more support for precautions like masking or social distancing. But when researchers showed messages like this to white Americans during kind of the height of COVID, they found that it didn't just reduce support for solving health issues, it made viewers less supportive of COVID interventions altogether. And so again, this is accurate, it's well-intended information, but instead of increasing public support like you might expect, this also backfires. And then here's one more looking at behavior. There's a special type of UV camera that takes photos of people's skin and can reveal permanent skin damage. And it turns out that showing people these photos is a pretty effective way to motivate them to wear sunscreen. And this actually works. This does not backfire. And so you might reasonably expect that letting people compare their own photos to people with more sun damage might be more motivating because it could act as something like a warning. But actually, this additional context cancels out all the positive benefits of the original intervention. And in a rational world, this extra context on other people shouldn't impact how you view your own information. But it turns out that looking down on people with worse outcomes somehow makes us feel better about ourselves, and this can be kind of demotivating. And so again, this is another example of well-intended, accurate information that has that doesn't have the effect that we want. And so our first big takeaway then is that information can backfire, even when it's accurate and well-intended. And this is maybe the most important message that I can share. I'd like to make everybody just a little bit more anxious or cautious about putting new data out in the world, especially if we're not super confident on how it will be perceived or what its impact will be. Anybody have any data disaster stories to share? Any examples of backfire? If we think of any, feel free to post them in the chat. Would love to hear those. Okay, so knowing that information can backfire is a good start, but even better would be to kind of understand how it happens. And so these are my 5 M's of kind of misunderstanding information, and I'm showing all 5 to give a sense of breadth. There's a lot of ways it can happen. But for today, we're going to dive deeper into this slice, these two, misattribution and misanthropy. And we'll start with misattribution. And so this is pointing the finger. Who do people blame for social outcome disparities? And in this next section, we're going to look at an important way that social psychology influences our causal beliefs about social outcomes. And to understand the problem, we'll look at this chart a little bit more closely. You can see, for example, that every year, 102 out of every 100,000 people from group B will die from heart disease. But this rate is much lower for other groups. But why is that? What causes these outcomes? And feel free to speculate. Genetics? Can people see my charts?
I can see them.
Okay.
I was gonna
Sorry.
speculate location.
Location, yep. That's part of my punchline later, so thanks for undercutting that, but that is Is the total 100 or is it 100,000 per group? This is the denominator here is 100,000, and so this is the bars show the number over 100,000. Social pressure, stress is a big one. Access to medical treatment, diabetes, comorbidities, other underlying diseases, comorbidities. Okay. All right, so a lot of people will explain these differences in terms of personal attributions or the personal characteristics about the people within the groups. For example, you might say that it's because one group drinks or smokes too much, or they eat poorly, or you might blame genetic differences, which has a whole other set of implications. But in reality, these differences are probably more reflective of external factors like access to healthcare or healthy food, or where they live, like living in red line neighborhoods or places with high pollution or lots of convenience stores selling cigarettes, or more broadly, structural racism. And these are, of course, US-centric explanations, but I assume that there are analogs in most other places as well. And so one of the issues with a chart like this is that since it asks people to kind of fixate on these between group differences, is that it subtly encourages viewers to blame the outcome differences on the people being visualized, because the social groups are the most salient factor on the chart. And this is one of the big concerns behind deficit thinking or deficit framing, which is fixating on these between group differences. And this is backed by social psychology. For example, the fundamental attribution error describes how people in Western cultures tend to blame people for behaviors and outcomes that are largely outside of their control. And our baseline results actually confirm this bias. In our last study, before people saw any of our charts, we asked them why is heart disease or liver disease better or worse for some groups. And we made them choose on a spectrum between either blaming external factors like pollution or insurance access versus blaming people's behavior. And as you can see, the distribution leans pretty hard to the right. When forced to choose, just 23% of people agreed that the differences were more driven by external factors, whereas 77% said that it was related to behavior. And so, of course, we also tested this question after showing them the charts. And we found that bar charts make these biases significantly worse. In our experiment, the bar chart condition shifted the whole distribution to the right. And so roughly 1 in 20 people who saw this chart changed their explanations from external factors to personal blame. And the problem with these personal attributions is that they are essentially victim blaming. If you believe that the outcome differences are because Group A has better behavior or genes than Group B, then you implicitly believe that the people in Group B are somehow personally deficient. And so charts like these can suggest a causal story that isn't accurate. They lead viewers to misdiagnose the underlying problems and then support solutions that can't work or that don't work as well. For example, no amount of lecturing people on kind of taking responsible for their health will close these outcome gaps. And these narratives around personal blame seem to just distract us from policies that might better address the underlying issues. And so our next big takeaway then is that conventional disparity charts misplace blame for social outcome differences. They blame people and not systems, because differences in outcomes can be misread as evidence for essential differences between who people are rather than the systems that they live in. And one of the things about this bias that's kind of wild is that once you start to look for it, you'll see it all over the place. And so an exercise that you can do to kind of practice this is just look for news headlines. For example, even kind of subtle choices like this one on the bottom left, this headline, comparing gun purchases with increasing deaths. Even choices like describing gun sales as gun purchases assigns responsibility to the consumers instead of gun manufacturers, at least in the US, who do quite a bit of marketing and lobbying to get more guns into more people's hands. And so there's a subtle framing, and this has a subtle blame to it. And the more you look, the more you'll see this. But what are some of the impacts of this misplaced blame? A few downstream risks might be undermining the political process, decision making in a healthcare context, or it can reinforce stereotypes. And so we'll trace through a couple of these. One of the concerns you'll hear from equity researchers is deficit thinking kind of acts as a distraction. For example, in an ideal world, a policymaker would look at this chart and understand that these differences are mostly driven by social determinants like housing instability, quality of health education, access to care. And understanding these systemic issues makes it much easier to rally around systemic solutions like subsidized housing or improving health education. But since these charts promote personal blame, they may distract people and policymakers from taking these social determinants seriously. And so these charts create misbeliefs that give policymakers an excuse in an environment to kind of avoid these issues entirely. Why take the risk of addressing a hot political topic when you can just point the finger at somebody? And so if we chain all these theories together, the end result is that nothing changes because it makes it harder for everyone to agree on what the underlying problems actually are. And so one possible way that charts like these might backfire downstream is kind of preserving the status quo through this distraction effect. And we'll do one more. We'll trace this through the healthcare system. We also found that charts like these can imply genetic differences between groups. And so you might read this chart as and kind of conclude that Group B is genetically more vulnerable to heart disease. And that's a problem if these are racial groups, because blaming racial disparities on genetics reinforces ideas that race is biological instead of a social construct that we all invented. And so these misbeliefs can affect healthcare providers. For example, one study showed that misbeliefs in biological race are associated with misbeliefs that Black people have thicker skin or that they have a higher threshold for pain. And these are not true. But even though these aren't true, it's apparently associated with Black patients being regularly misdiagnosed with pain. And so an even more dramatic effect of these charts is that it can create misbeliefs that reach the healthcare community and actually may create disparities in treatment. And these treatment disparities, of course, lead to outcome disparities. And so charts like these are potentially a subtle, indirect, self-fulfilling feedback loop. And so the impact then is that misattributing social disparities may make them worse. And so conventional health disparity charts that promote victim blaming have a risk of downstream impacts like undermining political urgency or even reinforcing disparities in treatment. And so that's misattribution. And the next big source of backfire we'll look at comes from misanthropic misbeliefs. And so this is divisive Dataviz. Can emphasizing group differences divide us further? In this section, we're going to talk about how our design choices can impact some of this, in particular stereotypes. And so let's jump into that. So we'll use the same motivating example from last time, but instead of asking, can these charts undermine health equity, we're going to extend it and just say, can they undermine health? And so in the last section, we talked about how these charts promote victim blaming. An even bigger problem here is that when these misbeliefs are applied to an entire group of people, it means that you're essentially stereotyping them. Because if you believe that these outcome differences are caused by differences in personal characteristics, you implicitly believe in a harmful stereotype that the people with the worst outcomes are somehow worse people. And so let's take a closer look at stereotypes then. Stereotypes are misperceptions of dispersion or variability. For example, let's consider a stereotype that people in this purple group are especially high earners. Stereotypes assume that within a group, people are more similar than they really are, and that between groups, people are more different than they really are. And so this stereotype implies a distribution like this one on the right, where not only do people in the purple group earn more, their earnings are very similar, and therefore all purple people seem to earn more than all other people. But in reality, even if average earnings for people in the purple group are higher than average earnings for everyone else, the distributions will still look something like this chart on the left. You can see that earnings are widely distributed within groups, and between groups, there's a lot of overlap. And this will generally be true for all kinds of social outcomes, especially when the groups are based on something as loosely defined as race. And so then our next question is, could certain charts create similar misperceptions? So we'll walk through another example, this time looking at earnings for 4 different groups. And again, the distribution on the left is close to reality for something like income differences between racial groups in the US. And again, you can see that there are a lot more differences within groups than there are between groups. And so if we take these distributions and plot them as a bar chart of average income for each group, we'd end up with a chart like this one in the middle. But when people see this bar chart, they may not imagine the distribution on the left. They probably imagine something more like this. Without any indication of variability, it's easy to assume that it's just not there. And just like with stereotypes, charts like these can create the false impression that people within groups are more similar than they really are, and that between groups, people are more different than they really are. On the other hand, if we show these same distributions as a jitter plot or any other chart that shows the range of outcomes within groups, it becomes much more apparent that within groups, there's a lot of variation, and between groups, there's a lot of overlap. And this actually parallels real life, where the more exposure you have to people from other social groups, the easier it is to see them as individuals and the harder it is to stereotype them. And so in our original research a few years ago, our basic hunch was that charts that emphasize within group variability, like this jitter plot on the left, should help readers see that outcomes are very different within groups and overlap between them. And this should reduce personal attributions or blame or stereotypes. On the other hand, bar charts or any other chart that emphasizes group differences should increase stereotyping. And we tested this with a bunch of different chart types and topics. And we also replicated it in this most recent experiment. And across 4 different experiments and 2 different studies now, we've consistently found that hiding variability increases personal blame and stereotyping. And so then our next big takeaway then is that hiding outcome variability supports harmful stereotypes. Visualizing people as monoliths makes them seem more monolithic. And so this is kind of a gloomy takeaway, especially considering how many public dashboards have this exact same issue still. But it's also encouraging because it means that our design choices, our chart choices actually matter. They make a difference. And so as data communicators, we have some agency in whether our work is helpful or harmful. And so we can solve some of these with different design choices. And so if hiding outcome variability is harmful, we can just make a point of doing the opposite. So we might consider a design principle like when visualizing social outcomes, we want to highlight within group variability and between group commonality, between group overlap. And so it can be tempting to try to reduce social outcomes into simple averages or easy sound bites like group X earns more than group Y. And we also know that comparisons make for more dramatic stories and they get more clicks. And so as communicators, our instincts kind of push us in this direction. We all value simplicity, we're all drawn in by a little bit of drama, and we all want our work to be seen. But being overly simplistic robs viewers of important context. And it can also make disparities worse by misleading audiences towards victim blaming and harmful stereotypes. And so social outcomes are messy, especially in the context of big complex issues like inequality or systemic racism. Rather than chase false simplicity, embracing the messy truth seems to give viewers a clear idea of who people are and where these disparities actually come from. And so when visualizing social outcomes, one thing we can do to minimize blame and stereotyping is to just show variability in outcomes. And this makes it easy to see how much outcomes vary within groups and overlap between them, and it makes it harder to misread charts as evidence for harmful stereotypes. And so before doing this work, I don't think that I fully appreciated the harm in harmful stereotypes. I thought it was just kind of misjudging people in school or on job applications. And it is those things, but it's also bigger. And so again, we'll trace a couple examples forward. So once our study and a few others suggest that charts or information like these can encourage harmful stereotypes and misbeliefs about the people being visualized. These misbeliefs have downstream effects on beliefs about health and on different manifestations of racism. And these misbeliefs and attitudes and prejudices contribute to environments that are less healthy to live in. For example, counties in the US with more explicit racial bias are associated with increased cardiovascular mortality for Black people in the United States, and also for white people in the United States. And this means that charts like these aren't just risky for marginalized communities, they may actually undermine health outcomes for people in the majority and for everyone else. And you can follow similar pathways for infant health outcomes, showing that counties with more implicit racial bias have more babies born preterm and with low birth weight. And there's a whole different pathway from stereotypes to reduce support for big social safety net programs like Medicaid in the US. Because we don't just stereotype people based on their social identity, we also form stereotypes about groups of people like Medicaid users or groups of people with common conditions. And these combined stereotypes together can undermine support for whole programs. And so our next big takeaway then is that harmful stereotypes harm everybody. Charts that promote harmful stereotypes about one group may undermine outcomes for all groups. And so taking all this together, charts like these may actually backfire and undermine public health. By now we know that good data viz good data can backfire generally, even when it's accurate and well-intended. We know that charts like these support misbeliefs about people and the causes of health disparities, and we can link these misbeliefs to worse health outcomes, at least associatively. And so charts like these, to the extent that they're out there and reaching big audiences, may very well undermine our health. And so our next big takeaway then is that there are consequences to the way that we visualize other people and social outcomes and particularly public health outcomes. Sometimes this data can help, but if we're not careful, it can also harm. And so given this potential for harm, if we want to avoid these backfire effects, it's good to start to try to understand some of these risks a little bit better. And it's especially important to remember that this isn't just about making clearer charts. There are all kinds of silly ways that people can accurately read a chart and still totally misunderstand what it says. And one way to get better at kind of identifying these risks is just to practice reading Dataviz more critically. And so for any given chart, whether it's somebody else's or something that you've made, you want to always be asking these three questions. What does the chart say strictly? What might the chart suggest if you were to kind of read too much into it? And what are the potential downstream consequences? And so that's all super depressing. But now the good news is that we can do better. And so we'll switch gears to talking a little bit more positive and proactive. Before we get into that, though, were there any questions about what we already covered?
I have a question, Eli. I'm not sure that I can formulate it quite yet, but when we're working with groups that are really trying to focus on populations of highest need, and the emphasis of our work is increasing access or increasing prosperity, whatever it is, in those populations of highest need, and that is Group B. Do you have recommendations on how to frame that so that we're still able to show impact, but also not create this myopic view of our
Yep.
work?
I do, and we'll get into that shortly.
Cool.
I think one so there's lots of different things to kind of balance with this. So like one is kind of de-risking and the stuff that we've covered already, and what we'll talk about in a second with charts like this one are kind of about de-risking. Um, but even this chart, as we'll see, or as we'll talk about in a little bit, is maybe not the best we can do. There's still different framings that we can explore on top of that that just look at kind of the groups of interest more directly and find other kind of useful comparisons because you don't necessarily need to compare one group to another. There's other contexts or other ways to kind of contextualize the group and their outcomes and kind of all the important things you need to know about the group as a community. And we'll get into more of that in just a second. But that's a very good question. All right. Nope, not there. All right. Let me find my notes. Okay. All right. So for this last bit, we're going to switch gears and try to apply some of what we've learned towards more positively influential public data viz. And so this is positively influential public data viz in 3 easy steps. And so in our Must Be a Tuesday study, we showed that this chart is a more equitable, effective way to present these outcomes. And so in this last section, I want to break this chart down a little bit, but I think even more important is kind of understanding the process for how we designed it and how we tested it, because we were very intentional about designing a chart that's not just more equitable, but that's also still kind of practically valuable for health agencies. And I think our framework for how we did this is something that could be easily adopted by other big institutions doing public data viz. And so I think there's 3 main steps. They're not necessarily easy. I lied about that, but they're not as hard as you might think. So these are clear, complete goals, designing with principles, and testing for impact. And so one way to unpack design goals is to start with a conventional chart and then try to work backwards and forwards and precisely define what are we trying to do with it, but also what might be better. What are the impacts that we hope to see from a chart like this? What are the risks? How would we know some new design is the unicorn that we're looking for? And there's actually 2 parts to this. So first, we can say that a chart is more equitable if it leads viewers towards more fair explanations for the outcomes that it's showing. That is, it's better if it reminds viewers that outcome disparities are more reflective of social determinants and not evidence of one group's genetic superiority or difference in their behaviors or their values. And then the second criteria is that the chart needs to actually be useful for the original communication goals. And the reason that these charts exist in the first place, at least for public health, is for communication goals like conveying risk, motivating healthier behavior or protective behavior, or encouraging public support for programs and interventions. And we need both of these criteria for a complete unicorn. And so step 1 is clear, complete goals. It's important to make sure that the goals are explicit, which generally implies putting them in writing, which also has all kinds of practical benefits for aligning stakeholders and things like that. But it's also important to make sure that they're holistic because being impactful on one dimension doesn't have to come at the cost of another. And we want to make sure that we're avoiding side effects on either front. And to be clear, I think that these criteria apply outside of public health as well. The specific measures might change, but overall, I think the game is we're trying to manage blame and stereotypes while also maintaining the original communication goals. And so our next takeaway is that positively influential public data viz starts with clear, complete communication goals. Data communication strategy should explicitly cover both equity and efficacy. And as we'll see, these goals aren't mutually exclusive. They build on each other. Okay, so that's step one. We have clear, complete communication goals. Next, how do we translate these into a chart? I have lots of opinions on what makes a good chart, and there are lots of good books on it and other talks. But the equitable part needs kind of more attention, and so that's where we're going to focus. And so for step two, we want to identify the key principles or considerations that help viewers reach fair conclusions about the people in the charts and the systems that they live in. And so these are maybe equitable data design principles. And then we also want to write these down. And there are lots of things to keep in mind, and there's no reason to write this stuff down or focus too much on it, because not all of them are relevant for every design goal. And to be clear, even though most of these have evidence, at least theoretical evidence, none of them are silver bullets. The more important part of kind of this step is being intentional. It's about identifying the risks that are most important to address and which trade-offs you're willing to make, and outlining specific strategies to try to handle them and writing them down. And so the value of kind of principle-driven design is less about adhering to a set of predefined guidelines and more about the process of choosing the right ones. And for this particular case, and for what we're hoping to study, these are the underlying principles that we focused on. And these first two are hopefully familiar based on the previous two sections. But let's look at how each of these might manifest in a chart. You can see blame systems, not people, in the title here, which says pretty directly, health outcomes vary widely by geography. And this isn't direct blame since it's not a causal statement, but it's still fairly on the nose. And then another idea is to consider is the value of being definite or unambiguous about the outcomes and relating them back to something that's concrete and familiar. And so in this case, we call out specific states with the two worst group outcomes. And this ties bad outcomes to places rather than just people. And then the next big difference is that instead of just showing average outcomes for each group as a bar, the jitter plot adds some extra context with dots representing outcomes for each US state. And this makes it very easy to see how much outcomes vary within groups and overlap between them. Like we said before, this makes it harder to misread these charts as evidence for harmful stereotypes. And then finally, visceral value judgments comes from some research suggesting that most people don't have an innate sense of whether numbers are good or bad. And people tend to take their cues from expert judgments and presumably also charts. And so painting these states in this kind of semi-alarming red helps reinforce that these outcomes are not good and that it's better to be kind of on the left side of this chart. But overall, what's so special about this chart? The design principles give us some confidence that the chart will meet our kind of unicorn criteria, but they also build up to kind of a more coherent theme, which was shifting blame to geography and not people, which is kind of the North Star for both this design, but also our study. And so our next big takeaway then is we want to design with principles. We want to identify and apply the design principles that we think will be the highest impact, and use these for inspiration when we're designing our charts and as a checklist for evaluating them. And again, it's less about the specific guidelines. It's more about kind of the process of generating them. But specific guidelines can be a good starting point. Okay, so we've got our goals. We've got our research-backed design principles. Our last big question is, does this actually work? It's kind of important to recognize that these explicit goals and design principles are a huge step forward, but again, they're not silver bullets. Since Dataviz is so contextual and task dependent, the best, or maybe the only really way to be confident that it's saying what you think it says is to test it. And to be clear, you don't need to recruit 1,000 people or publish a research paper every time you design a chart. But at the same time, impact studies don't need to be super complex. All you're trying to figure out is if the proposed chart or template is making things worse. It's basically just kind of an A/B test with surveys. And so if your work is reaching wide audiences or associated with some public institution that's highly trusted, running a few quick tests is well within your budget, and it's also a pretty efficient way to get to confidence. And so you'll use your original goals to figure out what to measure. For example, for public health, you'll probably focus on something like risk, behavioral intent, and policy support, like we did. And then for equity goals, a good place to start, again, is just where do people assign blame for the outcomes? And for each of these measures, there's all kinds of good questions out there that you can steal and borrow for your surveys. The ones that we use, we stole from one paper that stole it from another paper that stole it from like a third paper. And so borrowing, recycling questions is an easy way to kind of get started with this. And so the most simple version of this is setting up a survey where you ask all the questions up front before people ever see the chart. Then you stick the chart up at the top of the survey and ask the same person all those same questions again. And this will tell you for a single chart, for a single person, is it helping or hurting? Because you can see which direction they move in. For example, this shows our participants' baseline responses for the health communication goals, risk, intent, policy support. And this is how people responded before they saw any of our stimuli charts. And then after people saw the bar charts, their responses shifted like this. You can see responses all shifted to the right, indicating more agreement. And this suggests that bar charts were actually quite effective for raising risk awareness, encouraging behavioral support, behavioral intent, and promoting policy support. And this is good news. It means that the bar charts are at least doing what we kind of hoped they would do for one of our criteria. But the problem with bar charts is, as we might expect, how they impact blame and stereotypes. And so two measures that we looked at were, did people blame health disparities on genetics? If you remember before, this is associated with things like biologizing race, which can have implications for judgments about for medical decision making around treating Black patients and other things like that. We also had a question that forced viewers to choose between external attributions related to where people live or personal attributions related to how people behave. And we did this to see which direction they would choose when they're kind of forced to prioritize. And for both of these, the right of the scale corresponds roughly with more personal blame. And so now right is bad and left is good. We found that bar charts shift blame towards genetic attributions significantly and towards personal blame significantly. And both of these are bad. And so bar charts are good for risk, behavior, and support, but that's only half a unicorn. And since we structured this as a before and after experiment, this suggests that for equity goals, it's maybe actually better that people never saw these charts in the first place. But our goal here isn't just to gripe about bar charts. If we want to find something better, we need to test another condition. And so we tested this geoemphasis chart. And to really kick the tires, you want to generate a few different versions of the chart. For example, showing different diseases or different groups, and randomly assign one to kind of each participant. The most simple version of this is, again, just an A/B test where you're kind of seeing which one does best compared to each other. Or in our case, we kind of combined both approaches and did a before and after for two different conditions. And so let's get back to the results. This is the same plot as before for risk, intent, policy support, but now we're showing baseline results for both charts. This is, again, how they answered before they saw any of the charts. And what's remarkable is that for both of these charts, they were both quite effective for these conventional health goals. And this is good news because it means that the geoemphasis chart is at least as effective as the conventional bars. And this supports our next big takeaway, which is that we're not stuck with conventional bar charts. They might feel comfortable and familiar, but there's not an intrinsic advantage to them. This means that we can change the way that we visualize social outcomes without sacrificing our original communication goals. If an alternative design like the geoemphasis chart can create the same impact, that means you can feel relatively confident in adopting these new charts. And so now we know that both of these charts can handle the basic communication goals. And so they're both at least half a unicorn. So then let's come back to blame and stereotyping. And again, now we're looking at both charts And now right is more personal blame. And so right is bad, left is good. These were responses before they saw any charts. Again, same as before, the bars increase genetic blame. But now we see that the geoemphasis chart reduces it very slightly, but the influence is in the opposite direction. And this difference was significant relative to conventional bars, but not significant compared to itself. So this gap is significant, this gap is not. And then again, bars make personal blame significantly worse. And the geoemphasis chart makes it significantly better. It pushes the chart in the opposite, it pushes responses in the opposite direction, shifting viewers away from personal blame and towards structural attributions. And so again, because we measured responses before and after seeing the charts, we can make a reasonable case that bar charts aren't just relatively worse, they're maybe actively harmful. And on the other hand, the geoemphasis chart might actively help correct some biases that people already have, at least for this second question. And so altogether, what this means is that only the geoemphasis chart was the complete unicorn. It can handle basic goals like risk, behavior, and support, while also shifting misplaced blame from people to systems. It shifts blame from who people are to where people live. And so our last big takeaway then is that equitable visualizations support healthier populations. Data design choices like assertive titles and showing variability can play an active role in correcting health misbeliefs and harmful stereotypes, or they can make them worse. And since we can tie these misbeliefs to health outcomes, it means that making more equitable design choices is maybe actually good for our health, or at least, at the very least, it avoids making it worse. And so if we want to develop this habit of more effective, equitable data design, these 3 steps or this framework is maybe a good place to start. And then before we wrap up, and I've got an example, a more concrete example that we can walk through next, and I'll stop for questions towards the end, but a few final thoughts. I'm asking everyone to please save lives, stop bar charts. These conventional disparity charts are killing us, and maybe even literally. When we overemphasize the differences between social groups, we hide how much we all have in common and how much we're all in this together. This creates misbeliefs, not just about other people, but about how our systems are working or how they're failing and how they could actually be improved. The good news, though, is that we can do better. Design choices like emphasizing geographic variability may actually be corrective because they could shift blame away from the people being visualized towards the systems that they live in. And even better, as we show in our paper, alternative charts like these can be at least as effective as conventional charts for these more conventional communication goals. And even better than that, this is just one possible way to make these charts better. We're just getting started with this, and there's no rocket science to our 3-step framework. Anybody can do this. And so one of my projects for the spring and for this year is to get these more solidified and published somewhere. And so if people are interested in this or want to preview, feel free to send me an email. I'll send you a long, sloppy Google Doc, but I'd love your feedback. And if you're interested in diving into any of these topics further or how to apply this to your work, what we covered today was meant as kind of a whirlwind introduction for more humanely visualizing population health. Some topics we didn't cover: can looking at data visualization make people invincible? Why was Ignace Semmelweis really betrayed? And can waffles encourage vaccination? And so if people are interested in learning more or diving deeper, or if you think these are important topics for your colleagues, again, shoot me an email. I'm Eli at 3IAP. More than happy to talk about workshops or trainings. And then finally, my design practice is 3 is a pattern. Always looking for new clients, always looking for new projects related to using data for positive social impact. And so if you need help communicating health data or any other social outcomes, I'd be happy to chat. And again, this is anything from analysis to storytelling to designing reports, all the way up to launching custom web apps for more open-ended data exploration. Again, I'm Eli at 3IAP. Please feel free to shoot me an email. And I've got a link for everybody up here. This has references. This has links to the paper. It's got videos to other talks. all the follow-up stuff is up here. I made this just for you guys, and so it's there for you. So we got.
Thank you. I stopped recording so we can have our Q&A session.